So
Thank you, Senator Clinton.
To introduce Dr. Carolyn Runowitz, who is the Vice Chairman of the Department of Obstetrics and Gynecology at St. Luke's Roosevelt Hospital in New York. She faces the dilemma of what to tell her patients about mammography every single day, in fact, many times a day. And she's speaking on behalf of the American College of Obstetrics and Gynecology, and I'm delighted that she could be here with us on this panel.
We turn to Dr. LaSalle Gaffal, also, who's the chairman-elect of the Susan B. Komen Breast Cancer Foundation. He comes to us as the chairman of the Department of Surgery at Howard University, a position he's held for more than 25 years, and he's going to serve 1 year as the chairman of the Komen Foundation, which, of course, has been one of the leading advocacy groups, well known for its Race for the Cure, but for not only raising money, but also raising consciousness.
Good afternoon, Madam Chair and distinguished members of the subcommittee. I appreciate your invitation to testify today on behalf of the American College of Obstetricians and Gynecologists, or as it's better known, ACOG. ACOG continues to recommend mammography screening every 1 to 2 years for women in their 40s and annual mammograms beginning at age 50. We are here today because of publicity surrounding a study done by Danish researchers recently published in The Lancet. The Lancet study questions one of the most widely held beliefs in preventive medicine, that screening healthy people for cancer and detecting it early saves lives. It is important to note that this is not a new study, but a reanalysis of already existing published data. Scientific debate on critical issues like this one is common. ACOG supports periodic, evidence-based, peer-reviewed analysis of all available data on mammography, including a review of studies like the one in Lancet. We take its criticism of prior mammography research very seriously, and we want to make sure that the Lancet study itself stands up to rigorous review. In fact, the Preventive Services Task Force announced last week a different conclusion than that of the Lancet study. Their review of the data found that breast cancer death among women randomized to screening in 7 trials that included women older than 50 showed a 23% reduction in mortality. And contrary to prior testimony that you have heard today, in 1993, an independent analysis of the actual data from the 5 Swedish trials cited in the Lancet study showed a statistically significant 24% reduction in breast cancer mortality in the screened group. With such conflicting data, where do we go from here? Initially, I think all of us, members of Congress, doctors, patients, journalists, researchers, need to understand the difference between the very rigorous standards that scientific evidence must meet to clearly prove the worth of a test and the practicalities of what must be done in physician's office when conclusive scientific evidence, 1, is not yet available, or 2, may never be available. I make this second point because at this time and in the future, there would be clear ethical and moral problems in performing a randomized prospective clinical trial in breast cancer screening that medical scientists say are the highest quality of scientific proof. I ask you, how many women today would be willing to go without breast cancer screening in a clinical trial to prove or disprove a statistical point? We may have to live with certain amount of uncertainty when it comes to the results of mammographic screening trials. I also think we need to educate our patients about the facts behind the recent media hype, and that's what this is all about, media hype. While the Lancet study has raised several important issues, as a practicing physician, I have to look at this through the eyes of individual patients. I explain to patients that this debate has nothing to do with the effectiveness of breast cancer treatment. There is agreement that treatment saves lives. Instead, the debate is whether earlier treatment made possible by the early detection of tumors is better than later treatment. I tell them that early treatment made possible by early detection does make a difference. I explain why I think the accumulation of research trial evidence over the years has strengthened the science behind breast cancer screening, and that the data in aggregate demonstrate improved health outcomes with benefits outweighing the harmful effects. I discuss the recent controversy and my own recommendations. I explain that scientific debate on critical issues is common, but well-established guidelines should be followed unless there is compelling evidence to alter or abandon them. The news stories have already had a large impact on patients. They are confused, and they express a loss of faith and confidence in mammography. Some even misinterpret the media coverage and take away the message that mammography is bad and even causes cancer. Over the years, we have made significant strides in educating women about mammography by breaking down financial, physical, and psychological barriers to women seeking mammographic screening. I fear, as does ACOG, that these barriers might be reinforced by this negative attention and uncertainty generated by the media hype. As already mentioned by Senator Murkowski, I and ACOG are also deeply concerned that the ongoing controversy might discourage health insurance plans from covering this important screening tool. As frustrating as this controversy may be to the women suffering from breast cancer, the silver lining is that it brings to light a goal that we all share: the need to be even more vigilant in supporting research efforts to enhance not just early detection, but treatment as well as prevention and finding a cure for breast cancer. Until then, mammography remains as one of a number of strategies that can help save or improve lives. Even if the screening tests we have now are not as good or as conclusive as we would like, they are the best we have at the moment. As a practicing physician, I would be derelict in my duties if I advised women to stop having mammograms.
Much, Doctor. Dr. Lafall, and we look forward now to your testimony on behalf of the Komen Foundation.
In the early 1980s, when only 13% of women in the United States were getting mammograms, the average tumor size at detection was about 3 centimeters. By the late 1990s, when 60% were getting mammograms, the average detected tumor size was 2 centimeters. For many women, early detection means the possibility of less invasive treatments in some cases, as well as the option of breast conservation surgery instead of mastectomy. In the past decade, breast cancer mortality rates have declined in the United States, and Dr. von Eschenbach showed that on his charts. And this is due in large measure to early detection and timely treatment. And that's important, early detection and timely treatment.
Dr. Runowitz, I really appreciate your perspective, both as a physician and as a breast cancer survivor yourself. What is the best way for us to dispel the confusion and, to some extent, even more than that, the despair that women feel about knowing what they're supposed to do and who they believe and how they make these decisions? I think that what the American Cancer Society, the National Cancer Institute, and others have said, which is, I think, putting it sort of simply, you can't let the perfect be the enemy of the good until we know something more than we know now. It's prudent to continue to recommend the same standards that we have adopted. How do we get that message out?
I think that's a very big challenge, and one article on the front page of the New York Times can undo all of the good of all of the organizations. But I think hammering home the same consistent message and letting patients know the controversy is what science is all about, and that's how we make new discoveries. But until we have other data that makes us change these guidelines are based on good science, and we need to get that message out over and over again.